You have this in your handouts, and we've changed some of the slides to conserve some time for you, so you may have information that you won't see on the screen. Our goal is to prevent and heal cancer in our communities, and we do this here through education, research, and community clinical programs. We have two structures in cancer. One is the research structure, and our main programs in cancer are leukemia, skin cancer, and breast cancer. We do other things, but that's the focus of our research. In clinical programs, we have the green boxes along the side, our inpatient, outpatient, and off-site programs. In the United States, our care has been fragmented a little bit for patients. So if they're taking care of the inpatient, they have one experience. It's not so good sometimes, the communication between inpatient and outpatient for that. And then if they're cared for in the home, they hope they get the information we know about the patient in the home. So service line cancer is one of them. Attempts to, the next slide, pull the patient, everything together for the patient. Give them an experience where we hand them off from one site to another with continuity and care. About our oncology program, we have the Cardinal Bernadine Cancer Center, which we're going to take you on a tour through later. We have outpatient radiation oncology. The hospital, some of our services are in the hospital. Our children are cared for in the Ronald McDonald Children's Hospital. We have a center for home care at Homer Glen, which is about an hour from here, 45 minutes to an hour. And then we have an affiliated program at a community hospital near here. These are all the people that work on our team. These are all physicians of different specialties. And we have them nurses and other professionals that work genetic counseling. We have nutritionists, social workers, pharmacists, chaplains. We have a cosmetologist who does hair care and wigs. We have a licensed nail technician who will take care of our patients' fingernails and toenails. We have a nurse who focuses on patients who've had breast cancer and the prostheses that they need for that. And we have a speech therapist. I'd like to introduce Stephanie and Teresa, who are going to talk a little bit about the hospital here.
Hello, my name is Stephanie. I'm the Assistant Nurse Manager for the Inpatient Hospital 6 West. We have a 20-bed medical oncology unit right now, which is possibly expanding in the next couple of months to a 28-bed, which will also include some bone marrow transplant patients. Primarily, our patients have hematology malignancies, so that would be lymphoma and leukemia, but we also have solid tumors, breast cancer, ovarian, lung. Our average length of stay varies. Most of our patients who are newly diagnosed with leukemia stay 3 to 4 weeks. Our patients who are admitted for symptom management, such as neutropenic fever, stay about a week. As I said before, most of our patients are newly diagnosed, so there's a lot of education and chemo and health maintenance that we do when they're admitted. And then we do coordinate with the research nurse and our clinical coordinator, Teresa, for clinical trials. Our scope of care focuses on several different things: inpatient chemotherapy and biotherapy regimens. All of our nurses are certified through the Oncology Nursing Society for chemotherapy and biotherapy. We do give IV chemo, oral chemo. We also give intrathecal chemo, as well as biotherapy, which includes monoclonal antibodies. We do give a lot of blood and platelets on our floor due to the side effects of chemotherapy and neutropenia. Pain management focuses on pain from surgery, disease, compression, and we do give pain medication through IV patient-controlled analgesia and controlled-release morphine or Dilaudid. Our post-chemotherapy biotherapy symptom management includes neutropenia, mucositis, hair loss, nausea, vomiting, diarrhea, constipation, and fatigue. And we also offer palliative care in inpatient hospice, and we coordinate with Loyola's home health and hospice. And we also have hospice inpatient standing orders. And this slide just shows that each year our inpatient volumes are rising for inpatient cancer care. Now I'd like to introduce Teresa Fortenberry, who is our clinical coordinator for inpatient medical oncology.
Hello. Hi. Here at Loyola, we use a team approach. From the list that you see right here, from clinic nurses to social worker, we all work together to ensure that we deliver the best possible care for our patients. Our workflow relies on good communication so that our patients' plan of care are therefore implemented. First, I get a phone call from the clinic nurse. It could be a clinic nurse, our advanced practice nurses, and our bone marrow coordinators. After the patients are seen by the physician and they're ready for chemotherapy, I get a call from the nurses to find out what diagnosis the patient has and what kind of chemotherapy regimen they're receiving. Then after that, the admitting has to be notified. Some of our select patients, a couple of them with metastatic melanoma and renal cell carcinoma who are getting high-dose IO2 are always admitted in the medical intensive care unit because they have to be closely monitored. The rest of the other chemo patients are either admitted in the bone marrow unit or 6 West. And the next one, the hematology oncology services, they are also notified from the attending to the medical students, and this gives them time so they can review the patient's history, their chart, and make sure they can plan what tests are needed before the treatment is started. Next one is chemopharmacy satellite. I also make sure that they are notified of our elective admissions so that the chemopharmacist can make sure that they have the chemo drugs available that need to be given that day. Chemopharmacists are also our excellent resources for us because they're always there for us if we have questions regarding specific regimens. The inpatient unit, whether it's 6 West or MICU, again, the medical intensive care unit, the assistant managers and managers are notified so they can make sure that there is a bed that is available for our high-dose IO2 patients. For 6 West, what we do is we keep a calendar in the break room, and what we do is list the patients that are coming in for that day and with their diagnosis and with their treatment chemotherapy that's planned for that day. And having that available for a charge nurse is helpful because that way they can grade it an effective assignment, create an effective assignment for the unit for that day. Because there are days that we could have like 4 or 5 chemotherapies for that day. The research nurses play an important role for our team as well. With our research nurses, through clinical studies, doctors, our physicians are able to find new ways and better ways to treat different illnesses. So once I notify the research nurse, she can therefore review their chart, their history, and if the patient is eligible for a clinical trial, they'll see the patient, talk to them, and if the patient would like to participate in the clinical trial, then the patient gets consented. Also, our research nurses consistently communicate with the physicians and the nurses in-house, whether it's in 6 West or MICU, to make sure that the labs or any tests are done prior, during, and after treatment. Coordinating the care, line placement is important. If they already have a central line, that's great. If not, in-house, we'll make sure we arrange for PICC line or a Hickman because of the frequent blood draws that's required and also the chemo administration that's needed. So we make sure that they have a central line. Required tests for cardiac status. Some of the drugs that we give, the chemotherapy, can be cardiotoxic, so we would like to have a baseline, either an echo or a MUGA, to check their cardiac function. And the next is blood work for renal and liver function, because again, the way the drug is metabolized and excreted in the body, we have to make sure that their renal status and liver function are within the parameters. Pregnancy, if they are of childbearing age, we check to make sure if they're pregnant or not. And, hematological status, making sure that their counts have recovered before treatment. Coordinating our home care, I speak with the social worker every day, going over our list of patients in the hematology service and oncology service, assessing their home care needs, making sure that there are no safety issues. The social worker assess their insurance if they have to go home on home IV antibiotics. Our social worker is there to help us out. Family support, we want to make sure it's safe for the family, that they have a good family support system when they go home. Need for education, again, if they have central line that needs care, make sure that they're educated, and also neutropenic precaution guidelines. Because of their counts are low and they're mildly suppressed, they are very susceptible to opportunistic infection. So we make sure that the patients and the family are aware of those precautions. And coordinating care post-treatment. Discharge planning starts on the day that they are admitted. So when they're finished with their chemotherapy, we make sure that they have a follow-up appointment with their hematology doctor or oncology doctor, whether it's 1 to 2 weeks after treatment. Setting up frequent labs. Setting up frequent lab draws 3 times a week, whether it's through home care or through the clinic, and I make sure that that's set up as well. And the social worker is very helpful for that. Setting up appointment for medication administrations. One of the common drugs that we cannot give inpatient is Neulasta. When they get chemotherapy, they need the Neulasta shot to help to get their counts to recover their white blood cells. So what I do is make sure that they have an appointment to go to the cancer center after they're finished with their chemotherapy, so they get the shot. And the last one is coordinating central line care. Again, when they go home, we want to make sure that they have the supplies at home and they are comfortable with the line care and things that they need to watch for as far as infection. Thank you.
Are there any questions about inpatient cancer care? No questions. One of the complicating things I think that's pretty evident from what Therese said, because of the way reimbursement is in the United States, a patient is getting care in the hospital. A piece of it's not paid for, so they actually leave the hospital, drive down the block to the cancer center, come in and get an injection. Because in that way, it's reimbursed.
You mean chemotherapy?
Neulasta, a growth factor, a supportive care drug, So it's complicated, but our payment system here is very complicated. Okay, actually, Janet and Janine, another complication of care in cancer is that we have a national nursing shortage, and we particularly have a shortage of cancer nurses in the United States. We're aging, and I'm an example of that. So we Many of us are retiring, and so there's a shortage. So Janet is actually taking care of patients, and I'm just going to cover her content for her. And Janine, who's office manager, is actually helping with some of the coordination back in the cancer center. So one of the situations we have in our cancer center is, you saw our inpatient volume was growing, so our number of cancer cases are growing every year, but our building can't grow. So our clinics are kind of fixed. So we've been kind of hovering around this level for several years. That's why we've done some clinics off-site away from this medical center out in the community to try to find other places for our doctors to see patients closer to the patient's home.
What is the number, volume, visit volume or female?
Physician visits. Right, so 70,000 in our cancer center, 70,000 patient visits to physicians a year.
A year?
A year. In our cancer center, we have clinics for surgical oncology that are staffed by nurses who have a background in surgical cancer. We have licensed practical nurses who assist the registered nurse, patient care techs, PCTs, and then secretaries who are service representatives. So those are the people that help us deliver the care. And we take care of a wide range of malignancies, so all types of solid tumor cancers that are operated on, that are removed, or that are dealt, or a surgeon deals with. Pancreas, biliary, all the things that are listed here. We have hematology oncology clinics. Those are about half of the visits that you just saw. The 70,000 plus visits are hematology oncology clinics. Same team who work with it, work with the patients with these cancers. We have a skin cancer clinic. Our most common cancer in the United States is skin cancer. So we have a physician, a dermatopathologist, who works with Mohs surgery. They do a microscopic surgery. So if I have a skin cancer on my face, they actually shave it, and then they look at the pathology under a microscope. And if there's not clear margins, they shave another level. They can do this up to 8 times to get the cancer gone. And what it does is it preserves healthy tissue. It reduces scarring, and it's currently the best way we have for dealing with some of these skin
So the
cancers.
MOH is shaving?
It's Mohs. It's the name of the doctor who invented this technique.
就是那个MOH 是哪个医生发明这个方法，把那个皮肤剃那个毛，所以
When we take you through the cancer center, we'll show you where that's done.
去会看的，一会儿直接看到。
We have a cancer risk assessment clinic. Our physicians and nurses work in the cancer risk assessment clinic, and we have a genetic counselor who helps with this. And they actually look and calculate out what your risk for cancer is based on family history, your genetic profile, and we can provide services to support patients. Again, part of our goal was to prevent and detect early cancers in our community. We have a survivorship clinic. Because of the success of treating cancers in the United States, and I think across the world, there are more cancer survivors than there have ever been before. We have about 10 million in the United States. Some sources say 12 million. So people living beyond 5 years, Kelly's going to talk about this better than I, with cancer. So we have a physician in Kelly and a psychologist who see patients who have had cancer, have recovered, and who need to go forward now, having been a cancer survivor, understand what their health care should be, what their monitoring should be, and Kelly can actually answer any questions about that. Okay, and actually, Kelly and Katie are both multidisciplinary coordinators who coordinate our cancer patients' care from onset through pandemic.
My name is Katie, and I'm one of the multidisciplinary coordinators at the Cancer Center. My primary focus is lung cancer.
And my name is Kelly, and my job is twofold here. I'm a coordinator for the GI multidisciplinary clinic. You see the malignant gastrointestinal cancer cases, and I'm also the nurse, as Barb mentioned, in the cancer survivorship clinic here. So we're going to describe kind of how the multidisciplinary clinic works.
So multidisciplinary is just kind of a fun name for, we get to have our hands in everything that goes on in regards to a cancer patient and their care. We kind of get to deal with the surgical aspect, the medical oncology aspect, as well as the radiation. Plus we get to have a bunch of ancillary staff and services that come in and help us out. So really we describe it as a collaboration of surgeons, medical oncologists, radiation oncologists, radiologists, pathologists, and nurses to provide consultation and evaluation for our breast, GI, and lung cancer patients.
Okay, so why use the multidisciplinary model? Obviously, cancer can be treated with different modalities, and as a convenience to the patient and to serve them best, they can come in and see all modalities at once. So they can see surgery up front and then get adjuvant chemotherapy and radiation, or opposite, get neoadjuvant chemo-RT and then come back for surgery. In this way, all of the physicians know of the patient. Everybody is aware that they're getting treatment up front, coming back for surgery, or the other way. It's also very educational for the staff. Every multidisciplinary clinic has a conference involved, kind of woven into the clinic, and it's 1 hour where the physicians, all of the physicians we mentioned, get together and discuss new patient cases. And from that conference, once everybody agrees on the best plan of care, it's presented to the patient during clinic.
So just while we're on that slide, just one more thing. Sorry, Jody. The second thing here, using more than one modality of care is often the gold standard. You know, cancer is a very tricky disease process. So a lot of times it takes more than just radiation, more than just chemotherapy, more than just surgery to treat it. So we think that one of the big advantages of having this kind of a setup, you know, multifaceted type of care is you get to see everybody at the same time, and they get to explain to the patient what their role is in the patient's, you know, plan of care. So it's just kind of advantageous in that way. So good and the bad. That's kind of what we just started talking about. It's a one-stop shopping situation. You get to see everybody on the same day that's going to have a hand in the patient's care. And it helps to ensue communication among the team. As I mentioned before, use of other services like social workers. We have dietitians that work with us. Genetic counseling, again, Lauren is, you know, plays a big part in our multidisciplinary team as well. When the patient leaves with their appointment, they leave with a pretty clear outline of what their plan of care is going to be. So their appointments are made, their procedures or tests are scheduled, and as well as their return appointment to the clinic for follow-up. Talk about that.
So the bad. It is what we call one-stop shopping. However, this makes a very long appointment day for the patient. In GI multidisciplinary, they come in at 1:15 for an orientation, at 2 o'clock see their first physician, hopefully see their second physician at 3:45 and then 4:15. So the patients, you know, come in around 1:15 and leave close to 5. So that's one big drawback, but with the pro, as Katie said, you leave the appointment, the patients leave, and they have a complete outline of their care. Another bad point, gathering together all of your records. Patients go to many different hospitals, see many different specialties in their journey of getting diagnosed with cancer. And sometimes getting together their CT scans, MRIs, their pathology slides, their notes from different physicians can be very difficult for some patients. It's very tricky to navigate our healthcare system. And also with the long appointment times and seeing each of the physicians, it's just very overwhelming. These patients are just becoming diagnosed with cancer, and now we're telling them, okay, you're going to have chemotherapy, radiation up front, here's all the information, and then you're going to have surgery. And they meet all these doctors and nutritionists, and it's a very overwhelming day.
So we thought we would just go through a typical appointment. I made the slides, of course, it's my clinic that we're going to talk about. But just a typical day in the life of a lung cancer patient when they come to our multidisciplinary center. It starts pretty early in the morning. 7:30 they check in, and our patient care technicians put them in the room, get their vital signs, put all their information into our computer system. From 8 until 8:30, they have that half an hour to consult with their first physician. And depending on where they're at in their disease process or what they've already had done in their care, they can either see a surgeon, a radiation oncologist, or a medical oncologist first. After that, like Kelly said, we have an hour conference where we go upstairs and we sit down with all the radiologists, the pathologists, all the physicians, all the nurses, and we look at all of the records that they've brought. We look at their pathology slides, we look at all of their CT scans and their PET scans, and we all come to a conclusion of what we think the best step, the best next step in their plan should be. From that point on, 9:30 until about noon, that patient sees the remainder of the physicians that are set up for them to see that day, and when they leave, they're going to leave with the plan of care that they came to find. So it works out pretty well. It's a rather long day. It's about a half a day that you have to commit to us, but when you leave, I think that people have a pretty good idea of what's going to happen and what the next step is. So that's it. That's what we do. Any questions?
Fair enough.
You're going to hear more about it. Will you repeat 9:30 to 12 o'clock? The patient see the remaining physicians, then they already see it at 8 o'clock, 8 to 8:30?
So there typically could be 3 different physicians that the patient could see, including surgery, radiation, and medical oncologist.
所以他8点到8点半去看一些手医生、化疗医生、药方面的。
So each physician gets a 30-minute time slot with the patient for consultation.
Each. So, so she's asking 9:30 to 12. So what doctor is seeing the patient?
So let's say they saw the surgeon first from 8 until 8:30. So from 9:30 until 12, they would see the medical oncologist and the radiation oncologist.
每个医生只有半个小时，譬如说8点到8点半就是看那个开刀医生，那9点半到12点就看其他的了，还没有看到这个病人的。
Sure.
Good morning. Good morning. My name is Tom DeVries, and I'm the manager of the Image Renewal Center. And the Image Renewal Center is a program that provides supportive therapy to help monitor the emotional and the image effects of cancer and its treatment. And we do have a number of services that we provide, and we have a number of professionals that provide those services that we'll talk about in just a moment. We have 2 certified mastectomy fitters. We have a licensed cosmetologist. We have a licensed nail technician. We have a receptionist and service representative. We have 2 chaplains in the program. And we also have 2 social workers. We have a speech pathologist and a dietitian. And our faculty consists of Dr. Jones, who's a geneticist, and we have a genetic counselor. And Dr. Mumby is a clinical psychologist. And Dr. Rao is a psychiatrist. We offer a number of support groups in the Image Renewal Center that meet monthly for approximately 10, well, about 10 months a year. We have a head and neck cancer group. We have a breast cancer support group. And a brain tumor support group. And a lung cancer support group. We also have art therapy once a week from one of the chaplains who comes in and works with our patients, the pediatric patients, as well as the adults. And we also have something called Jen's Kids, which is an outside organization that comes in also once a week, volunteers from Jen's Kid, to provide art services for pediatric patients.
For the kids, right? 间，
Yes.
就是小孩子的，帮助小孩子让他。
We've done a lot of community outreach over the past several years, working with various programs, the American Cancer Society, Gilda's Club in Chicago, the Wellness House, the National Ovarian Cancer Coalition in Wyoming. And some of the programs, the outreach programs that we have are an annual Cancer Survivors Day that meets the first Sunday in June. And we attract approximately 1,500 people to that, guests, patients and guests. We have 5 or 6 Relay for Lives with the American Cancer Society every year, and the Luchando Contractile Cancer, which is a health fair program at a school in Cicero. We have women's health events. We have an annual Living Well event that we do in the fall. We have a GI cancer dinner, which is during the month of March. We have an annual bone marrow transplant picnic in September. We've also worked with local libraries and churches for small health fairs and things like that. Some of the other programs in the Image and Nose Center, we have an annual prostate screening in fall. We've done breast cancer screenings. We have a risk assessment and prevention clinic. We do genetic counseling. And we also have a skin cancer screening that's usually done in May. Some of the other services that we offer in the center are hair care services. Our cosmetologist works with men and women who have lost their hair or who will lose their hair. She is able to cut their hair, style their hair. She works with patients who are in need of wigs. She also works with patients with skin care and skin care issues. We have a licensed nail technician that provides therapeutic manicures and pedicures. And again, we have 2 certified mastectomy fitters that work with the women in our multidisciplinary breast clinic to provide mastectomy bras, camisoles, swimsuits. We have a dietitian who provides nutritional consultation. And we also have a couple exercise classes. We have a yoga class and an exercise for wellness class that is taught every month.
Hi, my name is Linda Flem, and I'm the clinical nurse specialist for the cancer service line. And Tina Cabala's in the back. Do you want to introduce yourself?
And I'm the clinical oncology pharmacist for the outpatient.
So we're just going to talk about the day hospital, which is in the cancer center. And our day hospital sees an average of about 60 patients a year. And the treatments can range from 15 minutes to 6 hours. Just depends on what the patients are receiving. When you do the tour, you'll see the day hospital area. We do have 12 chairs and 8 beds. And we actually have a pharmacy area right on site, and the pharmacists are right there preparing the medications for us. The day hospital staff consists of chemotherapy competent nurses, and we'll talk about the training program that we have for them. We also have 2 nurses aides that work with the nurses, that help the nurses. And we also have 2 secretaries that work in the department to help schedule appointments for the patients. This is our chemotherapy competence program that we have for the nurses. All the nurses complete the Oncology Nursing Society Basic Cancer online course. And all the nurses also complete the Oncology Nursing Society Chemotherapy and Biotherapy course. So it's 2 classes that all the nurses have to take. We also have a clinical competency for the nurses in day hospital that are going to administer the chemotherapy. They will work with another nurse to go over their checklist and make sure that they're able to administer chemotherapy safely at the bedside, doing all of our safety checks, which we'll talk about in a few minutes. And also we do an annual competency. So every year we have a written competency and also a hands-on skill that we do. We've done, for the hands-on skill, we've done a chemotherapy spill, reinforced how to clean that up if that does happen. We've also done chemotherapy extravasation with the nurses, what to do if the chemotherapy leaks out of the vein, how to treat that. And the day hospital nurses, this is just kind of talking about some of the things they do. They administer the infusions. They also do a lot of patient teaching. They teach about the medications that the patients are going to receive, the side effects, the symptom management, what to do once you go home, what to do if you develop a mouth sore, if you have nausea. They also go over all of the appointments. So again, coordinating to make sure that the patient knows when to come back into the clinic or when their next treatment will be. And we also work with social work. Social work can come in to give the patients information on support groups that we offer. Sometimes patients may need help with transportation, getting to the clinic. And then many of the oral chemotherapies are very expensive. And the social worker can work with the patient to help get those medications covered.
Covered mean
To get it paid for.
Paid for.
所以就是没有钱付啊，社工也帮忙去找钱。
And we also use the dietitians. We have the dietitians come and see our patients, especially patients with head and neck cancer, because they have a lot of complex issues.
尤其是头啊、颈亢方面的病人。
The different types of infusions that we do chemotherapy infusions, biotherapy, blood components, hydration, antibiotics, and injections. We also have a central line blood draw room. Many of our patients have central lines, and they require blood tests before they get their chemotherapy. So this room is actually connected to the lab. There's 2 chairs in there, and it's staffed by a nurse, and she sees about 25 patients a day to draw blood. The only thing we didn't talk about was the chemotherapy checks, the safety checks that we have put in place. We have a triple check system. So the physician writes the order, and then the clinic nurse will check the order, will verify it, will check the dosages. We'll check the labs to make sure all the labs are okay. If there was anything like Teresa talked about, a MUGA, a heart test, or a liver function test, that's all okay. And then after the clinic nurse checks it, then the day hospital nurses also check the order, and they're checking everything. They check everything, check the labs, check the dosages.
Then it moves on to the drugs get released. The nursing notifies the pharmacy that the patient has been assessed, so it's time to make the chemotherapy. So a pharmacist, we have our own triple check within the triple check. We check everything again, the patient, the disease, the drugs that go with the disease, and the doses. And then we also prepare the chemotherapy. A technician prepares the chemotherapy, and another pharmacist checks that it's the right drug, the right amount, the right fluid, and everything's perfect as the drug goes back out to the nursing staff.
And then when the medication comes out to the nurses, then 2 nurses will check the medication against the order that's in the computer to make sure, again, it's the right patient, it's the right drug, everything is correct. And then the 2 nurses go to the bedside and to administer the chemotherapy, and they have the patient. They verify it's the correct patient, have to check their date of birth and their name before infusing.
She would like to have the information on online course, basic cancer online course.
I can give you the website is ons.org, and I can pull up a handout off of there before you leave today. I'll get you.
It's free. It's free.
No, ONS charges for the course. There is a private charge for it.
Oncology Nursing Society.
The Oncology Nursing Society. So we want to provide standardized education for the nurses, so that's why we use it right from our society, our Oncology Nursing Society.
And in-house and hospital, do you have any extra course that nurse need to?
The second course on the ONS chemotherapy and biotherapy course, we teach here, and that is through the Oncology Nursing Society. They provide all the slides, all the material that we cover, but we teach that one here. The first one we do on the computer, and the second one we teach here.
Chemotherapy and biotherapy.
Right, chemotherapy and biotherapy class. Yeah, that we teach here.
And that's free to
That, there is a charge for that also that we pay ONS. Even though we teach it here, because it's part of ONS, we do pay. They provide a book that all the nurses get. So there is a charge for that.
Who checks the chemotherapy administration skill? You say the competence of chemotherapy administration. New. So nurse skill need to check. Who check this skill?
An experienced nurse from the day hospital. So if you have a new nurse, they would get partnered with an experienced nurse who would check and make sure they do everything correctly. And they would sign them off.
Every nurse.
Every nurse.
Every year.
That happens for one time when they're first hired, when it's a new nurse coming in. And then every year, our hospital does a competency on chemotherapy. It's something written, it's a test that they take.
Every nurse.
That does chemotherapy, right, in oncology. Every nurse takes that test every year.
The cost of the chemotherapy and the biotherapy is every year.
The class, they only have to do it one time.
One time.
One time they take the classes, so you have to pay once for the online class and once for the chemo and biotherapy class.
Just one time.
Just
Not every year.
No.
So you explain centralized blood draw room again, please?
Sure. Sometimes patients have a line in their chest, and we didn't have enough room in the day hospital to see those patients and give the IV infusions. So we have a separate room that the patients will go in there, the nurse, like a portacath, the nurse would draw the blood in that room, and then the patient goes to clinic or goes to the day hospital.
他是在这边抽血而已，特别的我不知道，他会。
We have just a few slides on our off-site program. I think we talked about the fact that we were running out of space in our cancer center, so we needed to look for another place to see patients. Loyola has another building about 45 minutes away from here, drive, called Homer Glen, Center for Health at Homer Glen. So we actually have an area for image recovery, so Tom's program where we can help patients feel better about their hair and skin and nails, and a place where we treat them off-site, close to home. Patients actually like it a lot because they actually are close to home. They have a short drive. It conserves their energy. We can do procedures there too. Our physicians go out there, and we can do bone marrow biopsies and things like that. And these are all examples of places that cancer services are affiliated with in our system. We participate with the Heinz Veterans Hospital, which is right next door, as well as Gottlieb Memorial Hospital, which is another hospital we're partners with. So partnerships is a part of the way we deliver our cancer care. It's my pleasure, actually, to introduce Regina Conway-Phillips. Regina is not a Loyola employee. She's an employee of the American Cancer Society. And she provides a really unique, she's the first nurse who does this in the country. And so I'll hand it over to Regina.
It's good to see you all again. I saw you last week. They visited my center last week when they were here touring. The American Cancer Society, it's a nationwide community-based volunteer health organization that's dedicated to eliminating cancer as a major health problem by preventing cancer, saving lives, and diminishing suffering from cancer through research, education, advocacy, and service. And one of the services that they provide is the patient navigation services. And I work for the American Cancer Society here in Illinois. So there are different divisions all over the country of the American Cancer Society. And one of our goals are to help improve the quality of life for cancer patients. And we do that by providing complementary enhancements to the current healthcare system. And so I'm here at Loyola to complement the services that they provide, the medical treatment and the physician treatment, and any social services. And so the services that they do not have, or I can implement those services through the American Cancer Society without charge. I'm also here to assure that access to the services, resources, and information across geographic, socioeconomic, and cultural boundaries. And the mechanism to reach the patient is often to reach those patients that have difficulty accessing healthcare system and the resources that are available in the healthcare system. We're positioned in different healthcare facilities, and usually the larger healthcare facilities that have cancer programs. The other patient navigators are social workers, and I'm the nurse that works here at Loyola. And we provide free resources for non-clinical needs such as wigs, prosthesis, Tom talked about the Image Center and that the patients can get wigs and prosthesis through those centers, but if the patients cannot afford those financially, then those services are afforded to those patients free of charge through the American Cancer Society. We also provide information about their diseases and treatment decisions, and so this information helps patients work with their physicians here at Loyola to make decisions about their care. And we also help patients with their day-to-day concerns, such as travel and transportation to and from their treatment and their appointments. If they have difficulty because their family works or they can't drive or they're concerned about driving, then the American Cancer Society provides rides, and these rides are usually through volunteers and through volunteer cancer survivors. And we also provide emotional support through programs such as Support for Recovery and Reach to Recovery. And this slide shows some of the different programs that the American Cancer Society offers. We have a 24-hour 1-800 line. We have a website that patients can go on to access information about the different types of cancer and the different types of treatment guidelines. We also offer a clinical trials matching service, so that if the clinical trials that are offered here through Loyola, if the patients don't qualify or are not eligible for those services, the American Cancer Society can also offer a clinical trials matching service. And here are some of the most frequent patient requests or assistance requests that the American Cancer Society receives through their 1-800 line and their website. And it's basically information about diagnosis and treatment, financial assistance, which they offer different programs to assist the patients with meeting challenges with regard to cost for treatment, especially those patients who do not have insurance or those that have insurance policies that are restrictive. And like I said, we offer transportation. We help to answer insurance questions. We offer support for family, for caregivers, and we offer lodging for families that have to travel to this area. The type of information that we provide is through the 1-800 number and through the website at cancer.org. We provide current information about the different types of cancer, the different treatment guidelines. We offer to help patients find hospitals and treatment locations. We offer local, state, and national resources with other national companies and organizations. And again, the clinical trials matching service. We offer emotional support through programs like the Reach to Recovery, which is a program that consists of breast cancer survivors, and it's a peer-to-peer support service, and so patients who are diagnosed with breast cancer can talk to someone who is at least 1 year out of treatment. We also sponsor the Look Good, Feel Better program, and that's where we have volunteer cosmetologists that come in and help patients work with their appearance and help them, teach them how to apply makeup and comb their hair and just help them feel better about their appearance and about themselves. And we also have Cancer Survivors Network, and that's an online community of cancer survivors and people in different stages of cancer treatment or survivors, as I said, and they can communicate with one another online and get additional information. We also have a program called Support for Recovery, and that's similar to the Reach for Recovery, but Support for Recovery covers all the other types of cancer. And so if you have a patient with lung cancer, they can call the 1-800 line and they can be matched with another patient or a lung cancer survivor, and they can talk to them one-to-one. And one of the slogans of the American Cancer Society is having cancer is hard, finding help is easy. Do you have any questions?
Is that course, online course is free and we can see?
Yes. Yes, the website is free.
Yes, it's for the patient education.
Yes. All of the information on the website is free. Most of it you can print out. It comes in PDF files, and you can print it. And you can also call the 1-800 line, and they can also give you information over the phone, or they can mail you information.
The 1-800 number, do they have other language like Chinese?
Yes, they do. Any other questions?
Once they call us or we'll call you, you get the names of patients?
We can get the names of patients if, for example, if I talk to a patient in a clinic, or if I know that a patient has been seen in the clinic and they've asked for information, then if they've agreed to have us contact them, then we can call them. I've emailed patients as well. They've given me their email address, and if I have to get other information that they're looking for that I don't have available immediately, then I can send them the information by email.
They have a question on the most frequent patient assistance request. The transportation, you will transfer the patient. What about their family? If the family want to visit the patient inpatient, do you arrange that transportation too if they don't have?
For inpatients, what we provide is lodging for the family, so that the family is housed in a hotel near the hospital, where they can then use local transportation to and from to visit with the patient. But the transportation that we provide for the patients is if they need to come in, for example, radiology, if they're getting radiology treatments and they have to come every day for 3 weeks or for 2 weeks, and the family has to work and they can't drive, then we have volunteer drivers that will go to their home, pick them up, bring them to the appointment, wait for them, or either come back and get them and take them home. If we don't get volunteer drivers, we have cab services that will come and pick them up and bring them back, and this is free of charge for the patient.
The criteria is that family could not give them transportation,
Right.
就家人不可以送他，送人怎么样？
他补助一些钱cover 他们的那个是不是应该有？
没有钱的。Financial assistance, do you mean you actually give them cash?
There are funds and there are organizations that have funds, like the Leukemia Organization, the Leukemia and Lymphoma Society. They have funds available. And the American Cancer Society has forms that they can complete and submit, and they can actually get cash for their treatment.
他是当时让你说条件一定是有条件的，他有表给他们填，和及格才可以拿到这个钱的。对对，一定也是有条件的。
And they also work with pharmaceutical companies if the patients can't pay for their medication. They work directly with the pharmaceutical companies to either get a reduced rate for their drugs or to get their drugs free of
还有他们
charge.
也跟药剂师做药的一方面也有会有交通，可能叫他们给药不用钱，或者减价这样子。
外面的药房不是？
药不是药房，做药的药
药
厂
厂。
还有其他吗？hotel， 这个是 hospital
你刚刚说那个什么？他刚刚说那个有电话，那个电话是从哪里去打？就是从那个网站那个网站。
No, no.
Okay.
Phone number is right here.
Okay. Okay.
Okay. 1 minute.
Thank you.
飞出队形的时候，就飞出队形的时候，就飞出队形。
management day 每天做什么？每天做什么？
像这个 reduce cost loss 就是这个费用的时候 loss
拿点注，他给他便宜一点注。
就是可能跟医院讲。
Hi, welcome. My name is Heather. I'm the nurse manager of the bone marrow transplant program, inpatient and outpatient. Our outpatient program is called the Hydro Therapy Unit. Right now I'm going to focus just on general facts about the bone marrow transplant program and then some facts about inpatient. Loyola's bone marrow transplant program is the largest in Illinois. We perform approximately 150 peripheral stem cell, syngeneic, matched unrelated, umbilical cord, and non-myeloablative transplants each year. We're a participating transplant apheresis and collection center in the National Marrow Donor Program Network. Our program is actively involved in research, providing a variety of clinical trials and studies for our patients to participate in. So we have up-to-date treatments that may not be offered at other centers. I just wrote a breakdown for the transplants performed inpatient last year. We had 133, and you can see we do mainly autos, and autos are transplants where patients get their own cells back. We do those both inpatient and outpatient. We also do allo-related, which is the transplant from a sibling. Allo-MUD, which stands for matched unrelated donor transplants, and that just comes from our donor bank. Allo-cords, which is umbilical cord, and then DLIs, which are donor lymphocyte infusions. And those just help reverse the process if the patients are losing some of the donor cells. So our inpatient bone marrow transplant unit is a 13-bed inpatient ICU. Within the next few months, we're going to be expanding our unit to a 15 private bed unit. So we're really looking forward to that. We treat a wide variety of hematological conditions. The main ones that we see are multiple myeloma, leukemias, and lymphomas. We do some testicular cancers and aplastic anemia. I listed ovarian cancers because we used to do more of those, but we haven't seen a high success rate in that, so we don't do as many of those. And then I just wanted to talk about our inpatient treatment process a little bit. So our patients are admitted. While admitted, they get a central venous catheter inserted. And then once they get that, they start a prep regimen of chemo. They can get chemo and radiation. They can get just chemo. Then that's followed by a stem cell, matched unrelated, or cord blood rescue. Then after they get their transplant, their counts all drop, so we give them blood component therapy. They become neutropenic, at risk for lots of infections. So they're on a slew of medications and antibiotics. Sometimes they get parenteral nutrition, so they get some nutrition through an IV bag. And then also they get stimulating growth factors, which is the new acid that we had talked about earlier. So once they receive all that, we wait for their counts to recover. Once their counts have recovered, they're discharged, and they follow, and home health typically follows up with the patient, and they're also seen in the clinic and or the outpatient therapy unit. The bone marrow team consists of attending physicians. Our bone marrow attendings are Dr. Stiff and Dr. Rodriguez. We actually have a new attending that's going to be joining us in September. We have staff nurses, which are all educated in bone marrow transplant and chemotherapy. And I know Linda had talked about how they become chemo certified, but I just put them, they have to complete the online basic oncology course, which also has a specific bone marrow content to it, a 2-day chemotherapy biotherapy course, a week chemotherapy administration practicum, and they also have to be EKG, ACLS, and critical care certified. Our patients, if they require any critical care, intubation, they do stay in our unit. A lot of other hospitals in the country on bone marrow transplants. If the patients need intubation, they go to their medical ICU. But here at Loyola, our patients stay no matter what. We have nurse practitioners. We have 5 of them. They're trained to perform certain procedures by the physician and plan and direct patient care under guidelines developed by the medical director of the unit. Collaborative care exists with an intense focus on the multidisciplinary plan of care for each patient. So they see the patients. They also help educate nurses on new bone marrow guidelines and chemo. Other members of our bone marrow team are the transplant coordinators. They see patients from the very beginning once they're diagnosed and they're coming in for a transplant. They see them, they educate the patients, they help them with insurance questions. They just get them ready to come in for transplant. They do also see them once they're inpatient as well. We have a dietitian who goes over the low bacteria diet with all the patients that they're placed on when they're admitted. We have a social worker. She helps with the patients if they need some funding, if their insurance isn't really helping them. There's different funds that she can have the patients sign up for. We have a clinical psychologist that comes to see the patients, chaplain. We have physical and occupational therapy that actually come to our floor and see all of our patients. We have home care. And we also have research nurses who follow the patients when they're on research studies. And then we kind of bring the whole team together. Inpatient works very closely with the outpatient bone marrow just so that we're all aware of all the patients, all on the same page of care for the patients. So the way we do this is we have a bone marrow education / caregiver class. So prior to patients getting transplant, the patients and their caregivers, those that will be staying with them once they're discharged from the hospital, attend a 4-hour class that's presented by the bone marrow coordinators. The nutrition presents as well, physical therapy, and they just go through all the necessary information patients need to know prior to being admitted or having their transplant outpatient. We do daily rounds on the unit with the attending nurse practitioner, the nurse, manager, assistant manager, social work. So we all round up the patients daily so everybody knows what's going on with the patient. Then we also have we have discharge rounds on Mondays. And there are some of the same people that are there, the nurse practitioner, nurse manager, the RN caring for the patient, home health comes, social worker, and the bone marrow coordinator. So we go through the list of all the patients in the unit and talk about who's ready for discharge. And if they're ready for discharge, if the things that they need for discharge are done. For example, they're on a lot of medications when they're in the hospital and they need to be on all of those when they're discharged. So it takes some time to order all their medications and make sure insurance covers it. And so we just kind of see who's ready to go home so that we can get them ready. We also have on Fridays interdisciplinary rounds, and everybody from the bone marrow teams at that, including the attending, the coordinators, nurse practitioners, nurse manager, research nurses are there, a lab technician, apheresis, psychologist, social worker. And at that meeting, we go through all the patients that could possibly be coming in for a bone marrow transplant. So all the patients that the attendings are seeing out in the clinic. We talk about when they could possibly be coming in, any issues that there might be. We go through the whole list of patients. Our social worker also has a support group for the caregivers. Inpatient, we have that on Friday, and the outpatient is on Tuesdays and Thursdays. And this is really good because the caregivers, the focus a lot of times is on the patient, and we sometimes forget that the caregiver who's visiting the patient every day, they have needs too, and it's nice that they meet other caregivers and they can all talk about things going on and compare things with their loved one, what's going on with someone else. And then we also have patient family conferences where the NPs, the coordinators, the nurse manager, and the social worker around at least once a week on the patient and just ask them what their needs are, make sure they understand their plan of care, and answer any questions they might have. And then just a little end note, we're really excited. This year we're celebrating 20 years of bone marrow transplant at Loyola, and every year we have a picnic where all the survivors and their loved ones come and celebrate. So this will be a really special one that it's 20 years. Any questions? Who's in the support group? The social worker leads it, and it's patients' family members. Each patient, when they're admitted, has to have, we call it a caregiver. It's usually a family member, it could be a friend, but it's somebody that has to stay with the patient when they're discharged 24 hours a day, 7 days a week, because they're still pretty sick, they still need a lot of care. And a lot of times we find these caregivers are also the ones that are staying with them inpatient as well. So that's why we have a support group. Thank you. Hello, my name is Sheila Wojtowicz. I'm one of the bone marrow transplant coordinators. I'm going to talk to you about our outpatient transplant unit that we are very proud of. And it truly is the state of the art. And it's really, we're just so proud of it. We started it in September of 1997. And it's located here in our cancer center in their lower level. And it's open 7 days a week, holidays included, from 7 a.m. to 7 p.m. And the idea here is that we do mostly our autologous stem cell transplants here in the outpatient center. And so it allows the patient to come here at 7 in the morning, and then by 7 in the evening they can go home, either if they live close by or else to a nearby hotel. And then therefore then they can stay in a comfortable, familiar area that, they get a chance to get out of the hospital. They're not in the hospital for the full 3 to 4 weeks. Okay? It's staffed with RNs who, of course, have had oncology and bone marrow transplant experience, supported by the advanced practice nurses who have oncology and bone marrow transplant experience and help to guide them when needed. And then also they're under the direction of the bone marrow transplant physician. Okay. They report to the manager, Heather, and also to Jamie, the assistant manager, and for any assistance in caring for these patients. And then also as well, everyone reports to higher management, which is our administrative director of the cancer service line, who also reports then to the vice president of the service line. Okay, as far as our professional standards, we do utilize the oncology nursing standards. We are followed by the Foundation for Accreditation of Cellular Therapy, acronym called FACT, and then which will be surveyed pretty soon. And then American Society Blood and Marrow Transplantation as well. Okay, the patient's room. There's 12 private rooms there, which we can house each patient. Each room has all the advanced medical monitoring that you would see in a hospital. So therefore, if there's any emergencies, there's everything available to attend to that. We have a TV, VCR, things like that to help so that it can entertain them and help pass the time as they're waiting there.
There's also in each room private bathrooms for the patient to use only, as well as a telephone, so they can make outside calls. Okay. Throughout the unit, we have what's called a HEPA filter, a high-energy particulate air filter that helps to protect the patient. It filters out some viruses and dust particles from the air. And then it also allows then for the patient to be in the unit with their loved ones and visitors without having the visitor wear a mask and so forth. And then we do ask that family members or any children stay away if they're ill. Even a common cold can be really detrimental to our patients. So we have that. Every night the rooms are cleaned thoroughly so that the next day they come back, then they have a clean room. And sometimes even in between patients, if they're just there as follow-up care from the inpatient unit, the rooms will also be cleaned in between each patient use. Okay. And for the patient's comfort, we ask that they try to think of it, create it like a home-like atmosphere. So we tell them to bring books, things that if they're going to come here every day, we want all those things here for them, and they can store it in the room there. They can put up pictures, things like that, that makes them feel comfortable, feels like, you know, they're seeing their family. They wear casual clothes, like you do, so that they, you know, feel comfortable if they're being seen by anybody else. They can walk around, things of that nature. Meals are provided for the patient. We usually do like a continental breakfast, cereal, so forth. Lunch and dinners, they can pick from a menu. Usually, and of course, we're providing a low bacteria diet for our patients. As for the visitor guidelines, we try to limit it to 2 at a time, mainly to help control infection. We do have the antiseptic hand gel dispenser right outside the patient's room so they can utilize that before they enter, because of course hand washing is the best way to help prevent spreading the germs amongst our patients. We ask that the visitors utilize the restrooms that are outside of the unit, usually located here behind the elevators, and there's also others in the building we would direct them to, and so forth. And we do ask they do not bring fresh flowers or any baskets. Moss does contain bacteria, so we don't want them exposed to that. For the caregivers, they're very important to us, indispensable part of our making this outpatient unit work, because we rely heavily on them to care for their patients, our patients, when they're leaving us. Okay, they're kind of like an extension of the nurse. It's here, you know, in the hospital, they have the nurse 24/7. Now, when they go home, it's caregiver. So we do educate them well. We make sure that there's home care that's our backup, and so forth, so that the caregiver can assess and see if something's going on. They can be able to call us and let us know what's happening, and if we need to admit them, we can do so. And so as far as what they do, they provide the transportation for the patients who come to and from the outpatient clinic. They help us, like I said, monitor them and assess for any if they're getting dizzy, lightheaded, things of that nature. We ask them to measure every, the intake and output every day so that they can bring that information back to us, so that the doctors will have that to be able to assess the patient's health status. They're also, administering meds orally and intravenously as well at home. And then, like I said, reporting the signs and symptoms back to us. Okay. Financial support. Of course, it's very expensive doing a transplant. And sometimes some of our patients, as I mentioned, have to stay in a hotel instead of a home. So that's an additional burden on their expense to pay for that hotel. So we look for financial support, utilizing our social worker and so forth to help them to navigate. Looking at our nurse navigator back there, it's a very useful tool for our patients. We do have community outreach programs. A lot of the American Cancer Society is utilized a lot for us. We have the patient caregiver education classes. We have the family support group meetings that allows the caregivers to meet other caregivers and share their experience, maybe get some helpful hints as to how to take care of the patient at home. Because usually it's your loved ones that's taking care of you. And let's face it, a lot of times they won't listen to you. And they'll, balk at anything, when you're telling them to eat and they got to exercise and things like that. So sometimes they need that support to know that they're not doing anything wrong, it's just the way the patients tend to react. Okay? We do have the annual bone marrow transplant survivor celebration, and then Relay for Life is utilized. Our future here for high-dose therapy is to continue to provide the autologous stem cell transplants. We like to do especially all of them. Right now, our Medicare patients have to be done in the hospital so that it'll be paid. But hopefully, we hope that will change and allow us to do some outpatient. And then we'd like to continue to limit the amount of patients that require the hospitalization. Right now, since 1998, only 27 patients had to be hospitalized, and that was out of 160. And that's less than 20% of the patients. And it was usually due to infections that we had to hospitalize them. Okay? And then hopefully in the future we'll be able to do the allogeneic stem cell transplant. We do some which is considered a mini transplant or a non-myeloablative transplant. Still very little. We still, so we're hoping that eventually we'll get there. And then also, because it does help us to keep the cost down for both the institution point of view as well as the patient. The costs stay down utilizing the outpatient center. Okay. Any questions?
The outpatients, most of the bone transplantation is outpatient, and the environment of their house is I think can take more chance of infection.
Yeah. What we do is we ask the patients, we have strict guidelines as to how they have to clean their home. They have to do a sterile clean from top to bottom, like what we call spring cleaning. So they have to, if they have carpeting in the home, they have to shampoo the carpeting, and then they have to do a daily vacuum. It's a lot of caregivers. The same with dusting. They have to clean everything and dust, and we tell them to pack away their knickknacks because that's one less thing they've got to be dusting every day. If they have heavy upholstery drapery, then we have them clean it, and then we tell them they're best to keep it down because it tends to collect a lot of dust on the top. So it's the dust that acts as a vehicle to carry the viruses into their lungs. So we try to keep them free of dust and everything. So, and they do have, the caregivers have to do daily cleaning of the bathrooms. Hopefully, most places have 2 bathrooms in their home, so we designate 1 bathroom just for the patient, and then the caregiver utilizes the second. If they don't have that luxury of having 2 bathrooms, then they just share it, but the caregiver has to clean after each use, utilizing the bathroom.
I think it's very hard for the family.
Yeah, it's hard on the family, but in the long run, the recovery period is a lot shorter. They're not, usually because of the fact that they're getting up and about, they're having to change get dressed every morning and come in, so they're moving more. They're in their own environment, sometimes being out of the hospital. It's just psychologically, it helps them heal better and so forth. At first we were kind of scared. It was a frightening thing to do it outpatient, but in the long run, then it showed that it really was the best for the patient. And now our model, our unit is being used as a model for our neighboring states, such as Wisconsin, Indiana, and so forth. They've come here and they're utilizing our unit so that they can set up theirs. As long as you teach but patients and the caregivers, then they feel comfortable. And you have to have backups, as we have home care. So you've got to give them that support that they're not out there alone, and that there's always a way, that they can reach somebody on our team. So we utilize and give them all the phone numbers, everything that they can have handy.
Housekeeping, if the family comes to has resource to find another support to the caregiver, or the clean the house.
They can have someone come in and clean for them if they want. We ask them to have backup caregivers so that it's not put on one person and burden of doing everything. And that's why at the hotel, sometimes patients like to stay at a hotel because they do the cleaning. And we ask the hotel people to clean the hotel rooms the way we want it cleaned for our patients. And they do. And our hotels, some of them will offer our patients some discounted rates. Staying in there, some of them stay there for 3 months at a hotel. So, if it's an allogeneic transplant, they will transition. They'll go into the hospital about 3 to 4 weeks, and then they transition out to our outpatient center, and we see them there twice a week. So day plus 100, so about 3 months. Yeah. Questions? Thank you.
Well, we could take a restroom break, and then we'll take a tour. And then we'll come back to this room and have the last part, lunch and a panel.
他现在我们会去左边，然后去看他的房间，然后再回来，在下面讲一个也是不判断的。
讨论这样，还会讨论这个。
Jody. Hi, we're going to get started again. We're at our last section, the panel. And what we're going to do is walk you through one of our bone marrow patients, how they go through the process. And then we also have... And we're also going to talk about the radiation program that we have here as well. So I'm going to go ahead and introduce you to Tess McCoo, who's the Director of Radiation, and she's going to present on her program.
Okay, I just have a few slides, and I just want to highlight some of the things that we're doing in the department. The place we visit is the main department, and that's where we do all of the radiation treatments, the radiosurgery, the high-dose therapies, and also the physician.
Yeah, there you go. There you go. Okay.
And also all of the consultations are done in there. In addition to the main department, the physicians also hold clinics at the cancer center, which we visited. And the third piece is that we have a contract to run the radiation oncology department at the Heinz VA, which is in the back of Loyola. There are certain procedures that we cannot do at the Heinz, so those patients also come to Loyola for treatment, for specialized treatment. These are some of the procedures that we're doing in the department. The traditional external beam radiation therapy, the high dose and low dose therapies. These are for cervical cancers and for treatment of prostate cancer. The total body irradiation is the procedure that we're doing to support the bone marrow program. That is, the patients come in to the department in the morning, and then we give them a lag time of 6 hours, and then they return back to the department for total body irradiation. That is, the patients are positioned in front of a linear accelerator. there's a specialized type of beam intensity that we use for those patients, and we essentially eradicate the bone marrow of those patients. The fractionated and unfractionated stereotactic radial surgery is a specialized, highly specialized procedure where we're essentially doing surgery using radioactive beams. The patients come to the department right after consultation, and a decision is made that the patient needs treatment, and we take a computerized tomography of the tumor to generate a three-dimensional picture. And we use that picture and load it into radiation planning system so that we could essentially contour the beams to the exact shape of the tumor. And we do this so that we spare as many normal cells as possible and we stay just close to the tumor. Also, with this type of procedure, sometimes the tumors are sitting right close to a critical organ, like the heart or the spinal column. What the physicians would sometimes do is they treat first the edges very, very close to the critical organs to shrink the tumor, and then maybe a conventional type of radiation therapy can be done. And that is, we do radiosurgery and then we do a boost. That's what they're saying when they, in some of the literatures you would see boost treatment, and that's what they are doing. We also do what is called image-guided radiation therapy, and that is after we created the three-dimensional model of the tumor, we use MRI images, positron emission tomography images, and also use that in conjunction with our planning. So what typically happens is after the original plan is developed and we deliver some treatment, the tumor shrinks. And this is the reason why every 5 treatments, the physicians will take a look at those patients again, look at the plan, we do patient assessment, similar to what is done in the inpatient, where they look for mucositis, skin breakout, fatigue, and so the whole treatment and also the medical issues of that patient are looked at. Their medical issues in relation to the radiation therapy. So what happens is we continue what they are doing in the inpatient into the outpatient, so that the whole treatment of the patient is very similar. In our radiosurgery program, we started first with inoperable brain tumors. We started that program with that, and most recently, last year, we started expanding our services to whole body tumors. We started with brain first because those are mostly very rigid, and it's easy just to cone the beam into them and to position the patient. But we have developed techniques, and through research in the country, we have developed a way of localizing treatments to whole body. The whole body is a little bit more tricky because the patients are breathing, you cannot stop that. And there are some internal movements in the organs, like peristaltic movement, that shifts the tumors. Now, it's very important that we could pin the center of mass of the tumor so we can follow it in the motion. And we have the technology to do that now. So that's the reason why we pull technology from CT, from MRI. We actually can program our computers to say, this is the center of that tumor, and you follow it as the patient is breathing, or as the stomach is moving. So we have that. because we are delivering high doses of beams, and it's important that we are right dead center on that tumor. This is just again a reiteration of the fact that we use a multitude of technology in delivering our care. And that is, we pull images from regular X-ray, from magnetic resonance imaging, from PET, and from ultrasound. This is just an example of some of the images that we're doing. This is, on that side, it's a plain CT, computerized tomography slice of the tumor. This is the tumor here. That's the spine. On this side, it's the same image superimposed on an image taken using positron emission tomography. We fuse those two images, and what we see is that fusion tells us what are the scar tissues and what are active sources of metastasis. So this yellow area here tells us that that is an active metastatic site. We then put the same image into our planning system, and we do an arrangement of the beams that can target the center of that, target the margins of that tumor. So what we do here is a very integrated approach, not only in technology, but also of all the resources at Loyola. There's a lot of background collaboration occurring between the departments, because as you can see, we have to collaborate with radiology, with the inpatient units, with bone marrow, so that we bring a very seamless service to the patient. In radiation oncology, the team is made up, of course, of the physicians. We have nurses over there who's doing the care of the patient and doing the patient education, doing the assessment and follow-up of the patient. There's also a big team of physicists and dosimeters who is doing all of the technical planning and the arrangement of the beams, making sure that the linear accelerator is working precisely. Because we are talking in terms of millimeters of adjustment in the beams. We also have the therapists, the radiation therapists, who are actually delivering the radiation treatments to the patient. And then a whole slew of support services, the registration people, the therapy assistant who is working to make sure that at the time the patient needs the care, they are there. And so at this point, I'd like to turn over the discussion to my colleague, because again, we work as a team. Thank you.
Okay. Work together. So we start out with a referral to the physician. A doctor refers a patient to the bone marrow transplant physician. So the secretary takes the call. This is a 59-year-old female with recurrent Hodgkin's disease. The secretary takes down all the information, gives the patient an appointment, and also sends a letter to the patient's home. And then what happens is on the day of their appointment, the patients have to come with all of their medical records. And this is just a picture of our clinic, Clinic E, down at the bottom. And this is some of the team for the bone marrow patients. What would happen is the first person that the patient would see is the nurse practitioner. And the nurse practitioner would get a history and physical on the patient. And then after she's finished, the social worker comes in. and talks to the patient about social issues. And then once that's happened, now the nurse practitioner and the social worker will talk to the physician, and they review the patient, and then the physician goes in and talks to the patient and decides whether or not the patient is a candidate for a bone marrow transplant. And in this example, the patient is a candidate for a bone marrow transplant. So then the bone marrow coordinators, the doctor tells the bone marrow coordinators to come in and see this patient because they want to get the patient ready for a bone marrow transplant. So now when the bone marrow coordinators come in, and we have Sheila here on the panel as our example, this patient is going to have an autologous bone marrow transplant. So Sheila would provide instructions on the bone marrow transplant process, what she's already talked to you about as far as getting the home ready, also verifying insurance, both for the transplant itself and for home care, to make sure that there's home care coverage as well. This particular patient, before they could go to bone marrow transplant, has to have more chemotherapy. So then what the bone marrow transplant coordinator will do is set up an appointment for the patient to receive chemotherapy. This patient had to go into the hospital, onto 6 West, our medical oncology unit, to get the chemotherapy. And the bone marrow coordinator also schedules appointments for any further testing. So now this patient is admitted to the 6 West, our inpatient oncology unit, and receives chemotherapy. This patient actually had to come in 3 times, had to get 3 cycles of chemotherapy. And now after all the chemotherapy, the patient is in remission and ready for the bone marrow transplant. So now what will happen is the patient and family attend the caregivers class, that Sheila talked about, patient education class. And the patient...
The other one is 5FU.